Welcome back. Today we're going to continue our look at special senses, and this lecture will focus on actually two special senses that are combined in almost one organ. We're going to look at the sense of hearing and the sense of balance and equilibrium. It's kind of an interesting setup because we have two very distinct separate organs that are involved in two different functions but have been placed embryologically very close together. In fact, the two together occupy a space on each side of the head of about that big. Tiny, tiny microscopic organs. They share a nerve, the eighth cranial nerve, which you know by now is the vestibulocochlear nerve. Vestibular referring to balance, cochlear referring to the organ of hearing. So if we take a look at the first slide and get right into the anatomy, this is a cutaway diagram of the ear canal, and then the middle ear, which is the green part, and the inner ear, which contains both the organ of hearing, the cochlea, and the organ of balance, as well as the nerve that conducts it back into the brain. Now, the outside, the external ear, is an organ of itself. It is shaped for gathering sound. We can't move it as well as animals can to direct the cone toward the sound, but we have an ear that can collect waves. We are really not at the top of the evolutionary chain here, but we have a very good organ of hearing and an excellent one for balance. The ear is composed of something called the helix, or the pinna, which is at the top. The entire ear is called the auricle. Remember, there was an auricle in the heart because it looked like an ear. And then the lobule, or the lobe. I have no idea why evolution gave us that, except possibly to hang earrings. Inside the external ear, we have the auditory, or the external auditory canal, or sometimes called the meatus, which means opening. This canal is lined with a few hair cells and with glands that produce a wax called cerumen, and this protects the inner ear from foreign particles like dust. The cerumen is supposed to slowly dry up and flake out of the ear. Occasionally it builds up, as we all know, and can plug the ear and needs to be removed. The ear becomes progressively more sensitive as you go inside. It has a lot of pain fibers. Again, the body doesn't want anybody touching that part of the body. The boundary of the external ear is the drum right here, called the tympanic membrane. Now, if we go to the next slide, this is more of a close-up. Here's where we're positioned to look at this. So this tympanic membrane is a thin but strong fibrous sheet shaped slightly like a cone, as you can see there, and covered on both sides with an epithelial layer, an outer layer. So it's actually got three layers of coverings, and it is pressed upon by a set of three bones in the inner ear. Now, the fact that this part of the ear is open to the atmosphere, and then you have the inner ear completely surrounded with bone, but it has its own escape valve. If you look down here, you have what's called the eustachian tube, and it is a small, thin tube that runs all the way down into the back of the mouth, just behind the arch where you see the uvula. I'll show you that actually in our next lectures on the digestive system. This is a pressure equalizing structure. If, for example, at sea level, we have pressures that are the same on both sides of this canal. We've all experienced going up in an airplane. Airplanes are not pressurized to sea level. They're only pressurized to about 7,000 feet. So as we go up, the pressure in the airplane is what we're going to feel in the canal here on the outside, which is going to be lower than the pressure in this ear right here, the middle ear. And as we go up, this higher pressure from sea level is going to need a way out. Now, it can press against the eardrum and cause pain, or it can blow its way out into the back of the mouth through the eustachian tube. And this usually happens, even if the tube is small or inflamed, or if you have a cold. It's like pressing the bulb of a little eyedropper. You have the increased pressure here, which can easily blow its way out. But as we've all experienced, and babies experience especially because of their very small eustachian tube, it's on the way down that's the problem. So now what happens is you have low pressure in here, you have increasing pressure on the outside as we get toward sea level, and that starts to press in on the ear and cause pain. We need to equalize the pressure, but air coming back up may have more trouble getting from the mouth into the eustachian tube to equalize, and that's why we swallow or yawn. We do things that can make that tube open on the inside of the mouth, and occasionally it doesn't, and we can get terrible pain. You often hear all the babies start crying as planes start to land. Problem is even worse for divers who are not going down in atmospheric pressures of air, but pressures made by water, so that every few feet they're going under a much greater pressure against their drum. And they know to clear all the way down by holding their nose, closing their mouth, and blowing air back up through the eustachian tube. This equalizes the pressure. If they get to the point of pain rather than discomfort or clogging, they usually can't clear it. There's such a pressure gradient that they can't do it. And they'll have to come back up a little bit till the pain goes away, then clear. And experienced divers know how to do this and never get themselves into the position of pain. So that's the first problem we run into with this very small canal. The next thing that's absolutely fascinating is the evolution of these three little bones that are sitting here in the middle ear and transmitting sound to the inner ear. These little bones, or ossicles, which just means small bone, are shaped to have leverage and transmit and multiply the vibrations. Sound is merely vibration in air or water, and it's a vibration at a certain frequency and a certain amplitude. So we have vibration in frequency, cycles per second, which is pitch. The faster the cycles per second, the higher we perceive it as pitch. And we have amplitude, which is the intensity or loudness of the sound. And the harder the amplitude, the louder we interpret that sound. And there's the old question of if a tree falls in the forest and there's no one there to hear it, then is there any sound? And I think the question is one of physiology and physics. Physics defines sound as those vibrations. Therefore, the vibrations are present, there's sound. Physiology, we're looking really at the reception of the sound. So there's no sound if there's no ear. And you can't scream in outer space because no one can hear you, and there's no air to transmit the vibrations. In any case, if you look at the three bones, the first bone that is there to receive the vibration, the movement of this membrane, and this membrane only has to move the distance or the diameter of an atom of gold. I mean, that's really small, and yet it can be detected. Of course, there can be big amplitudes too. This membrane starts to vibrate, and the bone along here called the malleus, which means the hammer, is fixed along about half the length of the whole drum. So there's a lot of leverage there. You can actually see this bone. If you get a doctor to let you look in the ear, you can see the impression of this bone on the translucent and shiny white eardrum. It's not pink like this, it's actually shiny and white. And this causes a streak that you can see. That bone goes up and has a joint, an actual articulation with the second bone, which is called the incus, or the anvil. So the hammer moves the anvil. And then there's a third articulation here with the tiniest bone in the body, which is called the stapes. You can see this bone, you can hold it in your fingers, but it's very, very tiny. It's called the stapes because it's in the shape of a stirrup, and it has an oval footprint here against the inner ear. Now, when these bones begin to vibrate, the physics is such that these levers can amplify the movement from here to here by about 20-fold. Also, we're amplifying the power because we have a very big piston on this side and a very small one on this side. So when these move, we get both frequency that is detected plus amplitude. We measure the the amplitude in decibels, the loudness with which we hear sound. For example, 0 decibels is threshold of human hearing. We relate this all to humans rather than absolute value. And every 10 increase in decibels is about a 10x increase, 10-fold increase in the amount of amplitude or power. Just common numbers are rustling leaves would be about 10 or 15 decibels. Whispering is about 30. My voice right now is about 60. Shouting, 80 or 90. And then physical pain starts at about 140 decibels. And these values are important because we need to measure them, since high levels of constant noise can lead to nerve deafness, which is not curable. One of the things that's present here to help us not have this happen, in the inner ear, now this middle ear, now this is another much bigger drawing. We have a couple of muscles. Here's a muscle that's very, very tiny. You can barely see this muscle when you try to dissect it out. It's called the tensor tympani muscle. And you can imagine that if this muscle contracts, its ligament pulls on the malleus and holds it steady, and the amplitude is decreased. The frequency won't change much, but the amplitude is decreased. So if the ear is subject to too loud a noise, you can use the tensor tympani here to help. And here's another muscle which you don't see very well. We just show you the tendon to the stapes, and this is called the stapedius muscle. This is the tiniest muscle in the body. Say 90% of the time when we try to find it in dissections in the anatomy room, we really can't find them. And it does the same thing. It dampens loud sound. Now, the problem is that these cannot react instantly. So if somebody fires a gun next to my ear, that damage is going to be done before either the tensor tympani or the stapedius muscle can react. These muscles are good for constant noise. They will contract and stay contracted throughout the period of noise to try to dampen it. There are actually people who get paralysis of these muscles because of various reasons along the way of the nerve. For example, it's nerve number 7 that holds the stapedius muscle, and it's nerve number 5 for the tensor tympani. If one of those are injured and these muscles don't work, the patient suffers from something called hyperacusis, heightened hearing, which is very annoying and very painful. It doesn't matter that they can hear things at lower amplitudes, it's that they can't dampen the louder sounds, and these patients are very unhappy. If you come back now to this picture, we see that the stapes, which really looks like a stirrup here, attaches itself to this window here called the oval window. Now, I'm going to show you one more slide of this area before we move on. This is taken from the inside of the ear apparatus. It's showing you the drum from the inside. Here's the big malleus, the incus with its ligament holding it to the bone. Look at all the air cells in here. This is bone. The reason it has air cells is to make it light. And then here's the little teeny stapes, and there's the whole stapedius muscle and its tendon attached to bone. Here's this little window. This window is in our organ of hearing, which is called the cochlea. Now, if I look at this picture, we see the cochlea represented here to look like a chambered nautilus. And it is a spiral, and it looks just like a seashell you pick up at the beach, and its internal sections are very much just like the chambered nautilus. If we cut that chambered nautilus across so we can see it a little bit better, here's what it would look like. Now, pay attention to this area, which is the cochlea. We're going to look at this area later on. Here's the nerve, the hearing part of the 8th nerve. It's the cochlear part of the vestibulocochlear nerve. Here's the facial nerve, number 7, going right along with it. And you can see it has little chambers. What it has is 2 areas called the scala. These are the scala vestibuli and the scala tympani. We won't bother with what that means. And in the middle is a little duct called the cochlear duct. It's very hard to see how these function from this view. Inside this duct is our hearing mechanism called the organ of Corti. Dr. Corti was lucky enough to get his name on it. And what we're going to do in the next picture, this is the artist's representation of us having opened up and uncoiled the entire cochlea. So here we have the stapes against the oval window. Here's our external, middle, and inner ear. And while we're looking at this division, you might remember that babies get lots of middle ear infections. This is where they get it, diagnosed by seeing bulging of the drum. Sometimes necessary to put a needle or make a hole in this drum to allow out pus or infection or fluid. Coming back to the cochlea now, what you see in this chambered nautilus is we have one area here called the scala vestibuli, and it goes round and round and round with the entire spiral. And at the very end, it connects with another chamber on this side called the scala tympani. They both contain the same fluid called perilymph. Peri because it's around the outside, lymph because it's a fluid of water, salt, proteins that's like the lymphatics in our body. And it's exactly the same fluid with exactly the same connection. The reason we need this is this leads to another little window with another membrane, and this is the round window. It's called the secondary tympanic membrane. The reason that is necessary is that liquid and fluids are not compressible. When you press on water in a closed space, it will not compress to any extent. Here we have something that's surrounded by bone. And if we try to compress and vibrate the stapes to transmit our wave of sound, we couldn't do it. And the reason we couldn't do it is because we couldn't compress this unless we had another flexible membrane out here. Now we have this set up, so any vibrations that are transmitted through here will end up coming out the other end and be transmitted through the whole cochlea. So now we have a setup where we can transmit vibration through a fluid, and now we have to detect it. Inside the middle of this is the spiral organ of Corti. It has membranes. For example, on this side is the vestibular membrane because it's next to the scala vestibuli. On this side is the core or the organ itself, and then we have a basilar membrane on the other side. And in the middle, something called the tectorial membrane running right there. I'm now going to blow that up for you so you can see what it looks like on cross-section and at much higher magnification. Here we have bone. Here we have the scala tympani, the one on the inside where the round window ends. We have the scala vestibuli filled with perilymph, and here's the nerve coming through the bone, sending fibers back to this wedge-shaped organ of Corti inside the cochlear duct, and it has its own endolymph, another fluid that's entirely separate from the outer fluids. In here, this tiny little organ, and we are down to microscopic levels, is the organ of hearing. If we blow this up a little further, we can look and see a cross-section of what this looks like. We're down now to looking at single cells blown up, so this is very, very tiny. On this side, we have the basilar membrane. It has some blood vessels, it has some endothelial cells lining it, and on the top we have that tectorial membrane. Now, there are vertical supporting cells, which are not involved with hearing, but just give support to the hearing cells in here. We have an outer layer of hair cells. We've seen these before in different functions. They are cells with all the structure of a normal cell. It has a nucleus and mitochondria and all the organelles inside which make a cell function and live. These cells have their own nuclei, as you can see. And this is a triple row of hair cells that stick up onto the tectorial membrane. There's an inner one that's a bigger cell, and it also has these microvilli, or hairs, that are about 50 to 60 per inner hair cell. Now, there's a few nerve fibers that come off these three guys and go back to the main nerve. And then there's a lot of nerve fibers coming off this inner hair cell, which actually transmit about 90 to 95% of all the sound. When we start getting the wave motion back and forth on the two sides of that membrane at slow, deep, low frequency, or very high frequency up here, these hair cells detect the movement because they are being rubbed against that tectorial membrane. And they transmit these vibrations in both frequency and amplitude back to the main cochlear nerve, that half of the vestibular cochlear apparatus. This is the way we hear. The brain then interprets this as sound, and as you know, we can detect an enormous range of sounds, not as good as a dog or other animals, but a very good range of sounds that can then be placed in context. We know about loudness, we know about songs, we know about very definite, specific things. I mean, we know when somebody's walking on leaves. We know when a door is shutting that we can't see. We can close our eyes and we can hear different things that we recognize from our memory and can define what they are. Extraordinary ability to do that. Deafness, by the way, since we are in this area, is a very emotionally debilitating defect. There are psychiatrists who believe that deafness is more debilitating emotionally than is blindness. Blindness makes it more difficult to get about. You can't drive. There are lots of things you can't do, but you have the emotional contact with the person with whom you are speaking or engaging in some social dialogue or activity, whereas in deafness, you're really shut off from a very important sense. And the adjustment to deafness is a much greater adjustment, much more difficult psychologically and psychiatrically. Loud noises, let me just focus on one of the really bad problems besides infections. Loud noises are very damaging to the nerves. The nerves deteriorate with loud noises. There are injuries, for example, to the bones in the ear so that the little ossicles that we talked about can be injured. And here in these joints, you can get something called otosclerosis that makes these bones not vibrate as well. The stapes can be removed and replaced. There's something called stapedectomy, if you can imagine getting into this tiny place with a microscope and actually operating. But nerve deafness is not curable, by and large. Loud noises do it. The louder the noise, the more the damage. And earphones are the worst because they focus the noise. If you're sitting next to your child who's listening to rock and roll and you can hear sound coming out of that earphone, it's too loud for your child. You should really insist that they turn that down because it doesn't come back. Now, we can do cochlear implants, believe it or not. We may not have the best ear, but we have the best technology. Surgeons can put in an implant that is sensitive to vibration and can transmit electricity to those nerves. It's not good hearing. It's certainly not great hearing, but it is hearing. And that, I imagine, over the years will just get better as everything else has gotten better. That leaves the ear and brings us to our organs of balance, the other part of this apparatus, which is called the vestibular apparatus. If you look here at this representation, here's the spiral organ of Corti, which we've already talked about, and here is the vestibular apparatus, which is characterized by 3 semicircular canals, and then an apparatus called the saccule and the utricle. Right here, this bulge is the utricle, this is the saccule. This is a little sac that helps replenish the fluid, not part of the apparatus except for a reservoir. Let's start first with the utricle and the saccule. These 2 organs are the basis of what is called static equilibrium. We have static and dynamic equilibrium requirements. We need to know in static equilibrium how we are positioned in space. Big problem for astronauts. We have gravity to help us. So there's a big sense that we have other things in our body. For example, if our vestibular nerve were not working, we would still have pressure against the bottom of our feet, vision to tell us. But in the absence of all that, in a swimming pool, you can usually tell your orientation in space. And that's called static equilibrium. This organ also, that detects static equilibrium, also can detect dynamic equilibrium, changes in motion. Let me go back to the physics for a moment. Dr. Wolfson in another teaching company tape talks about uniform motion. The body cannot detect uniform motion. It can only detect changing motion. For example, if you're in an airplane and the shades are drawn and the airplane is in level, straight flight, there's no experiment that you can do in physics to prove that you're moving. You throw a ball up in the air, it'll land in your hand. You jump straight up, you'll come straight down because you're moving with the airplane. You have to have an outside reference to be able to tell in uniform motion that you're moving at all. Once you accelerate, which means either changing speed or changing direction, you can get clues that you're moving. But in certain turns, like a one gravity turn in an airplane, you actually won't know you're moving, which is why pilots rely on their instrument panel and do not fly by the seat of their pants and the pressure they may feel from the environment. It's very, very deceiving and dangerous. Coming back to this, let's talk about first how we find our position in space. If you look at this area down here, the utricle and saccule, they have nerves going to the vestibular branch of the cochlea. Now, what the microstructure is here, looking now at very, very high magnification, we have both motor and sensory nerves that go up into this, through this basement membrane and into this organ. And again, we have hair cells that are innervated, and they're sticking up into a matrix. There's something very special sitting on top. This is very, very high magnification. If I go even higher and look at one section of this, here's the supporting cells again, holding these in position. Here's the hair cell, nucleus, and its organelles inside. And here are the motor and sensory nerves. This cilia, or stereocilia, because it can detect not only motion, but direction of motion. It knows not only that it's moving, but it knows which way it's moving. And it has 40 to 100 per cell. We're only showing 4 here. And they stick up at different levels into a membrane, which is kind of a jelly-like matrix with separations. See the little separations in them? This means that something moving over in this part won't necessarily disturb this part. They're very individual. But what's going to give this any ability, because it's such a light, tiny organ, has been the development of otoliths, ear stones. Look at these tiny little stones. These are actually calcified rocks that float on top. It's just like something out of a Rube Goldberg or Walt Disney invention that anybody would even think of this. This gives the whole system mass, so that if you were sitting there and perfectly at rest, this structure knows what position you're in, because when you move your head down, these stones, if this is forward, will move and bend this membrane and stimulate those little hair cells. So the hair cells will tell you, or tell your brain, that your head is moved. That's static equilibrium. It uses gravity to tell you the position of your body and mostly your head in space. This all really tells us about the head. It doesn't tell us about the rest of the body, but that's not a problem because of proprioceptors. We have all the signals in the joints of our body to tell us where the rest of the body is, and that can be interpreted relative to the brain. Think about this computer. It's absolutely extraordinary. Now, when I said it also detects some dynamic equilibrium, you can understand in physics, again, if this person were to suddenly put the metal to the pedal, or the pedal to the metal, as they say, and drive in this direction, inertia would make these otoliths lag and go backwards. That's the principle of physics. It's sitting here on a flexible membrane, so the hard part which is attached to bone, would go in this direction. The stones would go in that direction. And this saccule and utricle could detect dynamic equilibrium. It'll detect the change, but then when it catches up, inertia catches up, it will then sit there back in the middle again, and we'll be back to static equilibrium. So we have now one method of determining position in space. The next part of this comes in the semicircular canals. Let's go back and look at those again. We've now dispensed with the saccule and utricle down here, and we look at these semicircular canals. These are very tiny. I mean, again, you pick them up with a forceps. They're not very big. They're very fragile. They are embedded in bone, but if you try to get them out of the bone with a chisel, as we do in anatomy, it's an all-afternoon process trying to sculpt them out without injuring them. These are oriented in space. One of them is vertical. One of them is in a frontal plane, so it's got circular movement this way, and one is in a horizontal plane. So it can have circular movement this way. Between the three of them, we can now cover almost any change in moves in direction. If you look here, there is something called a crista within this swelling. A swelling like this is called an ampulla. You notice the canal filled with fluid swells at the end and is attached to this, within the ampulla, attached to something called the crista, which sends off nerve fibers again, three of them, back to the vestibular branch of the vestibulocochlear nerve. Now, this one is very different. This one has stereocilia, but they're oriented a little bit differently. They don't have otoliths. But here's the ampulla. Here's the swelling in this canal. And remember, it doesn't end here. It's a circular canal. It's called semicircular because of shape, but it's in every way in continuity. All this fluid is in continuity. And sitting within this is this object called the crista. Blown up bigger, it looks very similar to what we've already seen. There's this cupola at the top, numerous hair cells in it, and all attachments back to the central nervous system. If we set the fluid in motion, which it is not at rest, when I'm sitting here right now, these cells know that I'm at rest because nothing's happening to the fluid. But if I start turning my body in either this direction, or this direction, the fluid will be set in motion in the semicircular canal because there is a lag between the solid and the fluid motion. So here, someone turning their head is going to set this fluid in motion, is going to disturb the hair cells that are buried up in the cupola and send an impulse. And there's going to be rotational inertia that keeps the fluid moving for some period of time, depending on which way you're going. Now, you can visualize in a gross way how this will tell us what positional changes are going on. We got this very nicely demonstrated, actually, in medical school because we had something called the vomit chair, because almost everybody who sat in this chair would eventually vomit. It was a chair with arm straps, leather restraints to hold you in, chest and body, and it could be turned with a mechanism at very high speeds. So it was like sitting in a revolving chair that could be really speeded up. We all had the pleasure of doing this. What you could do then, if you rotated me around, you could set the fluid in my horizontal semicircular canal, and we were all blindfolded, and we would know we were turning and we would know which direction. Not a very big deal. We would also know when we were slowing down, when this was coming to an end. However, that wasn't interesting enough. What we would do is we would sit in this chair and be asked to turn our head almost as horizontal as we could get it. And then we would spin. Now what we were doing is your head, because it's on the side, was really spinning the fluid in the vertical chamber of your semicircular canal. And they'd get us going really, really fast. And then we would suddenly be stopped. What would happen is the body would stop, and the fluid would keep spinning really fast. So the brain interpreted that as an increase in this rate of change of spinning, which is actually deceleration. But what would we be thinking? We no longer were aware that we were going round this way, although we actually knew it in our higher centers, our cerebral cortex. Our brain interpreted this as if we were sitting straight up. It was such a violent movement that all the other logic systems were overshadowed. But all the brain saw was the spinning of the fluid in the vertical semicircular canal, and the brain thought we were pitching suddenly forward on our face. And every student, no matter how well trained, as soon as that chair would stop, would go boom, like that. Would throw their arms out, throw their head back, because they knew they were being thrown to the floor. Now, we weren't being thrown to the floor. We usually got very sick at that point. Everybody got sick who did this because basically it was a totally unnatural experience. Now, when you are in situations in which that is disturbed, there's sometimes very little you can do about it. Some training can help. The astronauts obviously are not up there in space tumbling and getting sick all the time. This can be trained out the way seasickness can. Seasickness is a combination of your middle and inner ear being disoriented to changes in your body position at a constant rate, as boat goes up and down, for example, and also problems in the change in the horizon. When people are seasick, one of the mistakes they do is they go below decks and they lie down because they feel so miserable. They close their eyes, and that makes everything worse because the only cue now is in the ear. And those cues from the ear tend to make you sick. And in fact, this was a great problem during the past world wars when we had hundreds of thousands of men who were at sea getting ready to land in Normandy, and many of them, if not all of them, were seasick, not in the best condition to fight. A lot of money has been spent on developing drugs to protect us from seasickness. But the best thing to do is to come up on deck, look at the horizon, and at least get a fix on your equilibrium by looking at the horizon through your eyes, being able to look at something and see what's going on out there so you can get your positional senses. So both dynamic and static equilibrium occur in tandem. They are not related really to your sense of hearing. Your sense of hearing only gives you very few cues about your position in space. It gives you cues about where noises and things are coming from, but it's really the eyes and the inner ear vestibular apparatus that work together to give you these kind of cues. Now, there are other things that can happen to the ear. I've already mentioned how constant loud noises can be a problem. There are diseases which are really so common. For example, if we look again at the ear, one of the most common things that can happen is perforation of the drum. The drum is a membrane. It has a very thin surface, and injury, for example, clapping really hard against the ear can create enough air pressure coming down the canal here to rupture the drum. That's usually a very bad event because it's a wild tear, and it can go through the bone. It can go through a lot of the drum and make for a very difficult repair job, if any at all. Sometimes the drum will heal with scarring, so you have a decrease in the sensitivity of the drum, and hearing will change in that side of the ear. The other thing that can happen is there are situations in which pressure can build up here. I've told you about otitis media, inflammation of the middle ear, very common in children. It seems to be more common in children who have been raised on foreign proteins. We have always, for many years, given our children cow's milk after breastfeeding. Cow's milk is a foreign protein. It doesn't come from our bodies, whereas breast milk does. in a place like New Zealand where the dairy industry is a huge industry and everybody is raised on cow proteins, children between the age of infancy and about 8 or 9 years old all get middle ear infections. It is almost a rite of passage to have polyethylene tubes placed in a child's ear. Nobody thinks anything about it because they don't even consider that milk might be bad for you at a certain age. So what happens is the surgeon goes in and makes a little hole in the drum under local anesthesia and places a polyethylene tube to keep that hole open. If I take a needle and pierce your eardrum, that sounds like it hurts, and it would, and I withdraw the needle, that hole will heal shut. And in fact, in adults who may have a bulging ear for one of many reasons, the ear, nose, and throat specialist will go in and just make a hole in the drum, let the fluid drain out. Once the fluid is out, it'll either heal shut or it'll stay open but with a scar around it, so the drum can still vibrate so there won't be any hearing loss. With the polyethylene tubes, however, they stay in for a long time, often until the child reaches the age where they're no longer allergic to the milk. I think we've all experienced how after eating dairy, ice cream, milk, you find yourself going afterward, and that's just a mild reaction of mucus formation because you have a little allergy to that milk. So we recommend that children, after they're off breast milk, go on some substitute like soy milk, which is not an animal protein, to try to prevent this kind of problem. We, as I mentioned, can do surgery in this area. It's microsurgery, very difficult, technically very difficult, and the results vary as to whether we can improve hearing in these patients. There's another series of problems. One is called Meniere's disease or Meniere's syndrome, and that's when the patients produce too much fluid in the vestibular apparatus. And these patients, because they have increased pressure in the vestibular apparatus, are moving the little hair cells inappropriately. And these patients are plagued with mostly dizziness, staggering, disorientation in space, and which often leads to vomiting again because those are connected. The vomiting center is very intimately connected with this apparatus. It's treated by trying to get rid of this fluid, often using chemicals, but it's very disturbing and disabling problem. There are other areas that are associated with disorientation in space. I've talked to you about nystagmus. We talked about looking at a telephone pole going by, the normal nystagmus, where your eye will tend to follow a fixed object and rapidly go to the next one. So you see the eye movement doing that. Depends on which way it's following the object. Nystagmus in a person sitting at rest, however, is a sign of usually inner ear or brain disturbance of that coordination system between the eye and the inner ear and the environment. And this is used as an initial diagnosis to try to figure out what's wrong with the patient. Then when you go back now to our other lectures, if we think about all the input that's being given so we can do something as simple as walk across the room. We have our visual cues. It tells us of position in space, tells us distance, tells us about obstacles, something very simple as that. We also have the proprioceptors in every joint in our body, feeding the information back into the brain, telling us the position and actual angle of every single joint. We have no conscious awareness of that until we focus on it. We look down at our toe and say, yes, I know where that toe is. I know my left leg is straight, my right leg is bent. Now, there are diseases that can get in the way. For example, one disease which was disappearing and is now returning is syphilis, a venereal disease, which has huge ramifications in all organ systems. It will be a disaster if this disease comes back and is resistant to antibiotics. Patients with third stage syphilis, central nervous system syphilis, called tertiary Louis, these patients have a defect and they cannot tell the position of their feet in their orientation. They still have their brain. They still have, for example, other senses of balance, but they tend to walk with their eyes wide open, their feet far apart because they don't have the proprioception, and they tend to put their feet out, lift them high, put them down. And the gait of a person with third stage syphilis is almost diagnosis. There's almost nothing else quite like it. Patient can walk across the room and you can tell what they have. So we have this huge complex of special senses that come together without any thought on our own to make us able to survive, move about, and be productive in our environment. This brings us to the end of the specific organs of the central nervous system and the peripheral nervous system. Next time we're going to take a look at memory and some of the other things that can go wrong.